Hello class, welcome to the last lecture. I wish this was in person, but we'll do it like this. We're going to talk about the uterus, vagina, breasts, birth control, STIs. It's going to be our last lecture on reproduction. So the uterus is a solid organ. It's hollow in the middle, but it has a lot of thick, smooth muscle on it. And it's pear-shaped, generally upside down. And in humans, it's just a single, let's see here, just a single structure like that, but that's unusual in mammals. If you guys dissected a cat in high school or something like that, you know, their uteri have forked like that, and you can have all the kittens along there. But we just have a single structure like that. It's an unusual uterus in the mammal world. But it has the function of holding the fetus, the embryo and the fetus, and keeping it there for 9 months healthy until it can be expelled during childbirth. Looking at the anatomy of it, the body makes up most of it, of course. Here's the body. The fundus is this upper portion. You can see where the oviducts will come in, and above that region is the fundus. Just like in the stomach, we had the fundus as an upper portion that gas would collect in. And then lastly, fundus, body, the cervix. The cervix is this region. It's a narrow tube. The uterus becomes more, instead of being muscular, it's more rubbery in that region, more connective tissue instead of muscle. And cervix means neck, like cervical vertebrae. So it's the neck that comes in with a little canal that goes through it. And of course, that gets really big, right, when it dilates for childbirth. When you look at this nice sagittal section of a person here, you can see that the uterus, the cervix comes in into the vagina here. And the vagina actually has a little, goes past it like that. So every woman's anatomy is a little different, the size and shape of the uterus and the cervix, but it usually comes in from the top, and it's a little circular donut with a tiny little hole in the middle. That's the cervix right there. You can just see to review, looking at the uterus and all these tubes those are broad ligaments. It's part of the peritoneum that holds all of it there. There's movement, but it's kind of tethered in place right there. You can see the ovaries close and attached to the uterus by a ligament. And then these oviducts or fallopian tubes coming down, the little fimbriae at the ends. And so depending on which ovary is ovulating, you know, your pregnancy could start on the right or left side. Fertilization happens way up here in the tube. And then that ball, the cell will start developing into a ball of cells. And then I was going to say if all goes well, if you want to be pregnant, that ball of cells will implant in that endometrium. So the uterus is changing all the time. That inner lining, wait till you see it builds up and sloughs off, builds up and sloughs off, right? So a lot of change happens in pregnancy. It just gets humongous, changes so much. So a lot going on there. Now, the uterus has 3 layers. The outside is the perimetrium, like perimeter. So that's connective tissue on the outside. I talk much more about that. The inner layer is the endometrium. And so this is the part I talked about that builds up and sloughs off every month with the monthly cycles. And it's building up in preparation for implantation of that ball of cells. And if there is pregnancy, for 9 months of developing fetus in a big sack of water in there. The myometrium is the muscle. It's smooth muscle, and it will, I'll talk about during pregnancy, it will just enlarge and it will divide quite a bit. And if you remember back from our hormone chapter, the endocrine system, under the influence of estrogen, it becomes really sensitive to oxytocin, right? So as this uterus grows and getting nearer and nearer to childbirth, it's ready, if oxytocin hits it, to do those contractions to push. And the endometrium goes through, of course, big cyclic changes. I'll talk about that next. The myometrium too. So with influence of hormones, it's going to change. Your uterus changes all the time under the influence of estrogens. There's a view of a uterus, entire thing. You can see endometrium, this region in here. Deep glands, you see these complex glands, lots of blood vessels. The opening is always a lumen in the middle. And then pretty impressive layer of smooth muscle on the outside. And yeah, it's freaky how big it can get. And the uterus will divide cells, hyperplasia and hypertrophy. The cells will get bigger too. And so you go from this tiny little pear, one of those big pears, like Bartlett pears, those big ones maybe, or the ones from Harry and David, like really big. That's about as big as a uterus is in a non-gravid female. And then it's going to, of course, get, you've seen pregnant people, right? I mean, it's going to get humongous. So it's pretty amazing. So let's get right down to it. The endometrial layer is the inner layer, lots of glands secreting a lot of fluid and a lot of blood vessels. Yeah. And the endometrium is correlated, endometrial cycle, with the ovarian cycle. So we talked about ovulation and that whole cycle. That is really going to control the uterus. Hormones are going to be controlling the uterus so that they're in sync. So if there's an ovulation of an egg, the uterus needs to be ready, like 3 days from now when the egg makes it down there to be implanted. And if there's going to be no pregnancy, you slough out all that endometrium and then start anew to make it new again. And then the eggs start developing again. So it's a cycle, of course. And so looking down here at the very bottom, we can see the menstrual phase is when it's being broken down. When by the end of the cycle, when you get near the 28 days, the corpus luteum is going to just start giving up, and start degenerating. And then your progesterone levels are going to dive, and progesterone was keeping that endometrium. Once that's down, the endometrium disintegrates, and that'd be the menstrual cycle. And as it's building up, this is going to be the proliferative phase where it's going to proliferate, grow. And then the secretory phase is where it's secreting fluids. There's lots of blood in it. It's maintaining that endometrial lining for a possible pregnancy. And so it goes menstrual phase, and then the rebuilding is proliferative, and then there'll be secretory phase as it's waiting, and if no pregnancy, you go right around to that menstrual phase again. Now, does the whole endometrium get sloughed off? No, there's going to be 2 layers here we'll talk about. The basal layer down here, that always stays, and it always has the blood and some glands. It's going to be able to make that functional layer above. So stratum basale, stratum functionale. Stratum is just a layer. And then the stratum basale, that's there even right after menstruation. And then the functional layer is what builds up in that proliferative phase. And it's interesting, the arteries that come up, they go through the myometrium, through the muscle, and into that basal layer being pretty straight, and they start corkscrewing. They really start spiraling up there. And those glands will form, the blood vessels will form. And then when they get destroyed, you have apoptosis, you have the blood vessels are constricted, so it's ischemic and the blood vessels die, and that whole layer you just built up starts dying and bleeding. And so that all just is going to go away. And you need that basal layer to have the blood vessels in the gland so it can regrow. You can't get rid of all of it down to the myometrium, or then you'd be done, right? So you always have that basal layer that stays with you, and then that functional layer builds up every month and gets sloughed off, just like that. And you look here, this is going to be at the beginning, it's growing. I'll just show you. And then here is where it's at its thickest here. It's a secretory phase. So you can see all those glands. You can even see kind of the corkscrew configuration of it. And you can see the basal layer here. Yeah, it does look a little darker, a little different. That's kind of the stem cell layer where it's going to always persist to make that functional layer. And this whole endometrium is about 1 to 6 millimeters in depth. And then here's menstrual phase. I can see blood, see the red blood cells everywhere. It's just breaking down all the way down to that basal layer. And then you start all over again. You start back and it'll start proliferating and start growing again and again, and it'll stay at the secretory phase waiting for possible implantation. Just a beautiful picture showing a uterus with that vascularization, all the blood vessels. This must be right and left uterine arteries coming in. So, like I say, characteristic of it is going to be these spiral arteries, and when menstrual period begins, you're going to like constrict this artery. It's going to stop the blood flow. You're going to have cell death and ischemia. You know, this layer is going to just come off like that. I think the spiral lets it kind of like constrict a little bit too. Pretty interesting. And then rich capillaries. It's so bloody because you're ready for a placenta to make a docking with it, a connection. And last, one more time just to show you, you can see this basal layer here is the one that's gonna stay, and you're gonna lose all this, that functional layer. And you see little lakes of fluid and blood and these glands that will come down and branch. And it's amazing, all this is destroyed every month, destroyed and then rebuilt. And putting together this, the ovarian and the uterine cycle. The ovarian cycle we did last lecture, you can see secondary follicle, primary follicle, secondary, mature follicle. Then here's ovulation, right in the middle, about day 14. And you still have a little ways if there was fertilization to the blastocyst, the ball of cells are going to get down to the uterus and implant. And by then, your uterine lining better be thick, bloody, moist, ready to receive that ball of cells. And if implantation is successful and a placenta forms, this whole apparatus of placenta and the fetus are going to give out hormones which will tell the corpus luteum to persist, and it's going to keep that inner lining. And it's kind of a tricky time period too, because if there's any glitch, any problem, and they don't make enough of that HCG, they don't give enough hormones out, then even though it implanted and it began the process, if that corpus luteum doesn't get the message and it degenerates, that whole inner lining with that implant is just going to be sloughed off. So it's going to happen probably pretty commonly, but if everything works fine, implants, the placenta can pump out enough hormone to tell the corpus luteum, keep it up, keep making progesterone, you'll have that layer. If you're not getting pregnant, corpus luteum is going to degrade after a couple weeks, 14 days, and then that drop in the hormones is going to cause all this functional layer to be sloughed off, all this cell death, it's going to be lost, and then you start rebuilding again. And then follicle stimulating hormone will get some of these guys going, so to make a new one for the next month. So just a couple slides. This is real nice showing you progesterone is going to make those endometrial glands, they secrete glycogen, so sugar, mucus, all the stuff that's being secreted out there. The blood vessels are just growing like crazy, getting ready to maybe establish a connection with placenta. And look at the beautiful, you can see the spiral kind of look to it right there. And just as I told you, if there's no fertilization, by the end of your cycle, you're going to enter the menstrual cycle, and the lack of hormones is going to cause that whole inner lining to be sloughed off, to be bleeding out, and then you'll start anew. beautiful. This shows you, you can see the difference here. You can see that basal layer looks different than the functional layer. This is the expendable one, the top one. But this darker layer means it's more cellular. It's more of a permanent fixture. And don't forget, myometrium is the smooth muscle. And here's menstruating. You can see mass destruction, right? Cell debris, lots of blood is going to be in there, and the ends of the vessels, the beginning of the vessels will constrict to keep you from bleeding, bleeding out, but you're going to be losing blood as this all degenerates. Now, if you did in fact build one of these, this placenta is going to be giving off that HCG, and it's going to go in your bloodstream. It's going to hit your ovaries, and your corpus luteum is going to say, oh, we're doing this, huh? And it's going to say, okay, we're going to stay here. We're not going to degenerate into a corpus albicans, and we're going to make your hormones to keep that uterus a hospitable place for that growing fetus. Now, this is a pathology. When you hear, I want you to know what an ectopic pregnancy is. An ectopic pregnancy is a pregnancy implantation anywhere than where it's supposed to be. Instead of being in the lining, it can be various places in the lining of the uterus, but anywhere outside of that, an ectopic pregnancy can't go to term. The most common type would be a tubal. And you can see how this can happen pretty easily. Now remember, the egg is fertilized up here. And let's say you've had an infection and there's a constriction along your tube somewhere. So this big developing ball of cells gets stopped, gets blocked there. It can't get past it. Well, it will start developing in the tube, and you'll have pain, and then you need to get surgery to get that taken care of. And I can say something even wilder here. Sometimes that egg, after it ovulates, I said it's popped into the abdominal cavity, but it may not get sucked into that oviduct. It may go over here somewhere, anywhere. And then remember, sperm, they're going to come in, and sperm can find it over here, and that can implant on your intestine, on a bunch of arteries on your intestine or your abdominal wall or on the ovary. And it'll make a connection. It'll start growing, but it's not an environment where it can go to term. But they'll find, women that died in their 90s, they'll find ectopic pregnancies, little remnants of that in the abdominal cavity where fertilization had taken place outside where it's supposed to, and it went there. And I'll take this time too to mention that men and women differ in that females have a passageway from the outside environment into their abdominal cavity that men don't have. Because the vagina is open to the outside, and then the uterus too, and then the oviduct, and then you're in there. You're in this nice sterile location. Rarely causes a problem because bacteria and such would have to get through all the mucus of the vagina and the uterus and the tube, and the cilia are moving the opposite direction. So, but it's there. There is actually an opening to the outside that we don't see in men. And so imagine from puberty in your early teens to early 50s. Every month, so 12 times a year, you go through this cycle of building up the uterus and in the ovaries of making a mature follicle, having it ovulate. So that's done again and again. So just estimating about 450 of these cycles in your lifetime. That's all you got. Could you have 450 children? Well, no, right? Not if you're going to keep it in your uterus, because a kid takes up most of a year on its own. So it's interesting to see. Well, you saw the record was 69. That's with triplets and quadruplets. But anyway, and then menopause by age 50, about half of women, and look, it comes up really quickly. By 52, 85% of women. So you can see if you're in your mid 50s, your chances of being fertile are really, really slim. And then some women after menopause will get these hot flashes, this screw up of the hormones. Because FSH will be released from your pituitary, but there's your ovaries are done, and there's not going to be estrogen release there. All right, well, moving down the uterus to the cervix. And if you were to see the cervix looking in from the vagina, it looks like this. It's like a round donut-shaped thing, solid, and there's a little tiny little hole in the middle. And there's a canal in here. See this light color? There's a canal in here. Yeah, and an external opening and an internal opening there. And before childbirth, your opening looks circular. But this thing, this little tiny opening, a millimeter or whatever, is going to go like 10 mil. It's going to be huge. It's going to dilate, isn't it? So you can tell looking at a cervix of a person that's given birth, things are going to change after birth. So it's one way of telling if a person has had a baby. And you can see also that the vagina is going to come up beyond the cervix. There's going to be these little dead end cul-de-sacs there. And this opening, so this canal is clogged with thick mucus. And then it changes monthly to get watery. It gets real watery around ovulation, then it turns thick again. So during ovulation time, it becomes more hospitable for the sperm to swim up there. So it changes every month so that can happen. And there's huge changes in childbirth into the cervix. It's got to get huge. And you'll hear, people having babies. My cervix is dilated, effaced. Like, what the hell does that mean? Well, effaced means the cervix also is going to shorten up and change shape. The dilation is pretty simple. It's how big the hole is. It's got to get big enough for that head to get through, right? The cervix changes quite a bit near childbirth. The connective tissue in there is going to start loosening. The collagen is going to loosen. It's going to become more from a rubbery to more pliable, and it's going to stretch. It's going to become more and more dilated as you get closer and closer to the childbirth. The cervical endometrium is not like the uterus, because the uterus is preparing for implantation. If you have an implantation in the cervix, it's not going to work. It's a little different endometrium. And I should say that the cervix produces most of the mucus. We'll see in a moment, the vagina doesn't secrete a lot of mucus. So the watery mucus that comes out is coming from the cervical glands and then glands near the opening of the vagina. So that mucus is produced in the cervix and lubricates the vagina coming down. Yeah, mid-cycle, 10 times. It's watery and favorable. It's getting ready for, in case there's a sperm that needs to go up there. And looking histologically, we're going to see the vagina is stratified squamous. And of course, it's going to be columnar inside the uterus. So this really shows that transition, doesn't it? You can see stratified squamous gives out, and it really changes. And as you age, apparently, stratified squamous goes further and further up that canal. See some more slides looking at that change. And the cervix is looked at a lot. The cell changes in it. We'll talk about cervical cancer in a minute. So here's an image here. You can see the vagina is this clear area, and here's the cervix coming into it. So we, in the US, do routine pap smears or pap tests. And you go in and you scrape some cells off the cervix, and then the pathologist can take a look at it. And so it's great. You can see in the US, we have a much lower rate of cervical cancer than other places in the world where they don't do this. So this screening is a way to catch cervical cancer early, because this can be one that's very slow growing, can go on for years and years and years. So if you get regularly tested, you'll be able to catch it early before it metastasizes. One cause of cervical cancer, a big one, is this virus, this HPV virus. And so you've heard or have gotten HPV vaccine. The idea is to give it to all young girls before they're sexually active, so they don't get the virus and thus prevent them from getting the cervical cancer. And just to show you, what do the pathologists actually look like? Well, here you can see some normal looking cells. And then when you see cancerous cells, you're going to see they're just over dividing. They have big nuclei. So you're trained to look for abnormal cells. And it can mean a lot of things. There's a lot of subtleties to what could be going on in your cervix. Vagina. In Latin, it means sheath. So put your knife, your sword in the sheath. It's a receptacle for the penis, obviously. So let's talk about that. You can see in males, they're only going to have 2 holes, right? Urethra and an anus. And in women, between the 2 will be the vaginal opening. And you can see it opens at what's called the vestibule, that area between the labia minora. It's an opening right there. And it's normally just a collapsed tube. And it'll go up. It has ridges on it as you go up. And then you can see the cervix protruding into it, can't you? So it'll be round like that. That cervix will come into it. And you notice even beyond it, something called a fornix or fornices. Or this dead end that goes beyond it right here. So that posterior one right there, like I say, is an area where we can put a laparoscope up and put instruments up there and do surgery in the abdominal cavity. And then you can sew that up and just take out your instruments and you don't see a scar. What else? Talked earlier about external genitalia. You can see this is the mons pubis. You develop at puberty, a bunch of fat and hair develops right above the pubic bone. The clitoris, you can see the erectile tissue in there. And then just to review, you have a prepuce, like a little hood that covers it. And the 2 labia, the labia majora and labia minora, with that vestibule being the area between them. And the hymen, yeah, there is a connective tissue, like a little skin that goes over there. And people will talk about it being, evidence of being a virgin or something like that. But it can tear and open for many other reasons besides sex. But it's sometimes that opening can be very small, but there has to be an opening there to let out the menstrual fluid. So the hymen is a little membrane there. Indeed, the vagina is a muscular tube. It's got smooth muscle along it. It has skeletal muscle just at the opening here. You got skeletal muscle. And then it's ridged. It'll be stratified squamous in there. And the mucus that comes out for lubricating only comes from the cervix and at the vestibule, not from the middle of the vagina. Sure. And of course it has a mucosa, a muscular layer, and connective tissue. This is what it looks like, vagina, in histology. So it's definitely stratified squamous, but no keratin, right? If it's keratinized, you'd see these little wisps of keratin, but no, it's not. It's stratified squamous because you have friction, either from sex or from babies being born. You're going to have friction in there, so you want to have multiple layers, but it doesn't need to be keratinized because it's not like your skin. It's not going to be waterproof. And then you see there's going to be smooth muscle surrounding it. But what's missing are the mucus glands. And like I say, it comes from the top and the bottom, the mucus does. So another view. It's a good way to show stratified squamous, non-keratinized is vagina. And the vagina is kept very acidic. Look at this low pH, very acidic. And you secrete glycogen, which is sugar, and the bacteria that live commensally, living with you symbiotically in your vagina, they metabolize and they give off lactic acid, these acids. So you keep it in an acid environment, and it keeps other bacteria from growing in there. So it keeps a nice, suitable environment that keeps bacteria and fungi and other things. And if you get antibiotics, sometimes it will throw off your acidity in your vagina. It will kill the bacteria, and you can get a yeast infection more likely. But it's interesting, you feed bacteria, the good ones that you want in there, to keep it acidic. And that's why semen has buffers, has basic chemicals to neutralize that acid, because the sperm want to be in a more neutral environment. And lots of elastic fibers so it could stretch, during childbirth. All right, looking at external anatomy. First of all, remember the bones. We studied the pelvises of men and women. And women have a have an issue here, that they need a wider pelvis because this opening has got to fit this head through it. And in evolutionary time, if your pelvis wasn't wide enough, you couldn't give birth and the mother would die and those genes wouldn't be passed on. So strong selective pressure for not dying in childbirth. And the head of the human, remember the fontanelles in the skull, so the fetus can squeeze out a little bit. Yes. So it's kind of jarring there, but we're looking at female anatomy coming at you right there. As I mentioned, the mons pubis develops at puberty. It's a bunch of fat that is over the pubic bone, men to a lesser degree. And then hair will develop in puberty as well. And then you have two lips, labia as lips. You have the outer, the labia majorum. And there's fat inside of them and hair on them. And then labia minora are the minor, the smaller lips that are hairless on the inside of those. And as you go anteriorly in those labia minora, you get up to the clitoris, which is the same as the male penis, but smaller. And then there's a hood, a little prepuce that's it looks like an extension of the minora sometimes, kind of comes up over there. That little hood is the prepuce, and it's going to be the foreskin that's going to cover and hide the clitoris right beneath it there. And that space between the labia minora is called the vestibule. So that's that space in there. What opens up is the vaginal opening, and just above it, the urethral opening. So in women, there's only one opening for urine, and reproductive materials come out the vagina. In males, the urethra does reproductive and urinary contents. And the anus here, this region here is called the perineum. And in males, it'd be the region between the scrotum and the anus, this perineal region. All right. So getting the clitoris, it is going to be the same thing that becomes the penis in the male. And so the glans is the tip of it. And that's the part that you see that comes out, and lots of nerve endings, of course. And the part you don't see goes into your body, and it has these two crusts, these two legs that come down, just like in the penis. Remember, it had a crust and a bulb in the penis? Here it's going to have that. It's erectile tissue. So it has the blood vessels that are going to cause it to become engorged. And then what happens to the other tubes there? Remember we had corpora cavernosum and spongiosum? These are called the bulbs of the vestibule. You have erectile tissue that's inside underneath, deep to the labia on either side of the vagina there. That'll become swollen too during arousal. So you'll have this erectile tissue there. The clitoris will become engorged as well. So this erectile tissue works the same in the male. Just everything is smaller, and the bulbs of the vestibule, erectile tissue on either side, here and here, and then clitoris will go back, and it'll go right and left as these two legs that come down. And here's a view looking at a sagittal section. Yeah, and your primary sex organs are your ovaries. These are all secondary sex characteristics out here, external, internal stuff. So looking from the side, hopefully you can see this. You can see labia majora, labia minora. And these are paired on either side. Clitoris is coming out here in blue, just peeking out from beneath a little hood that is the prepuce there. And you see the opening of the urethra and the vaginal opening here. And remember from urinary system, women more likely to get bladder infections because it's a short distance, a very small, short urethra. And then this gland, also called a vestibular gland, is going to secrete mucus. And they can become inflamed too sometimes, but normally they make mucus. So here's a helpful chart looking at the function of all these different reproductive organs in the female. And then the hormones, I've talked about it, but I guess I'll review just some high points here. So the anterior pituitary is going to release FSH and LH, right? Follicle stimulating hormone and luteinizing hormone. They travel in the blood from your head all over your body, and your ovaries are listening. And follicle stimulating hormone is going to cause those follicles to start developing for primary, secondary, and then maturing. And the luteinizing hormone, its main function, when that surges, you're going to ovulate. And as the follicles are developing, the bigger they get, and once they're a corpus luteum, they're releasing a lot of estrogens. And that'll actually have an inhibitory effect because you've already got the follicles developed. You don't need to be stimulated anymore, not until next month. And again, just to complete this, looking at it up here, you can see that you can have, remember, the anterior pituitary hormones, all of them, right? Growth hormone, follicle stimulating, thyroid stimulating hormone, all these things, they have releasing hormones from the hypothalamus, right? Your brain's really control. So hypothalamus will release gonadal releasing hormones, and that causes the release of those two. And so you can have negative feedback affecting directly on the pituitary, or tell the hypothalamus, hey, stop releasing the GnRH. And some of these hormones also in the female, development of breast tissue, and females put down fat in the thigh, buttock kind of region as well, and doing other secondary female sexual characteristics. And more of the androgens influence more hair growth and different kind of anatomy in a male. All right, mammary glands or breasts. These are a mammal feature, thus mammary glands, mammals. And they're not necessary for reproduction, right? You could just give the kid a bottle, I guess. But they're necessary for successful reproduction, pre-formula days for sure. So remember on dissecting the cadavers, I was excited, let's see what's inside these breasts. And disappointed, just fat. There's these lobules of connective tissue that kind of separated into different compartments, and then it was just filled with fat. And cadavers are 80, 90-year-old, no lactating going on in there at all, and they also regress in size too when you have less estrogen. And also, it's very common to have lumps. So they're benign lumps. So they get as you get older, those form, and you want to get them checked out. But it's often a case where they just get a different kind of consistency as you get older. But it's modified skin. The fat comes from what would be this subdermal, hypodermal fat, and what you have is glands that form within it. The mammary glands form within the fat and these little lobules all the way around the breast. And those glands secrete a modified sweat that has lots of fat, has antibodies in it, proteins, all these things to nourish our offspring. And milk probably first evolved. You look at our most primitive mammals, they just have a milk patch and a platypus on their belly, and the infants just lick the milk off. There's no nipples or anything. It's one hypothesis. It was just to help with immunity, to pass along antibodies. And then we've kind of run away with this idea of giving nutrition to our young through the milk. The anatomy of the breast itself, and men and women have breasts. It's just that women are much larger because under the influence of estrogens. The nipple obviously is the nipple, and then the areola is the pigmented portion. It actually gets darker with women and during pregnancy, during hormones. It stays, even after once a woman has had birth on. It's usually more pigment in the areola, probably as a target so the baby can find it, so it survives. It can get its milk. This also shows the lymph nodes. Certainly, they're showing. One concern is breast cancer I'll talk about, and so the lymph drainage is important, and a lot of it goes into the axilla, the armpit, and so cancer cells can travel from the breast to the axillary lymph nodes, so they're like sentinels. They want to look at those to see how far it's spread. A nice view of the breast here opened up. You can see that the glands, they're actually alveolar glands, which means they're kind of in little pouches, and so they produce the milk into this space in there, and will travel through what's called alveolar ducts from the alveoli. And right here I would call these lactiferous ducts, lactiferous. Oh, my handwriting's terrible. And those are going to be carrying the milk, and there'll be little holes along the nipple. That's where the milk will come out of these little ducts right here. And when you first lactate, you produce this yellowish liquid called colostrum. It has a lot of antibodies, and then the milk, typical milk will be produced. You can see the breast sits in fat right above your pec major muscle, so there's movement. You can move it around pretty easily. And then within it, this doesn't really show it, but there's ligaments called suspensory ligaments that come down and hold the breast. And the nipple's usually like around T4, but it just depends on the size and shape of the breast. But so they sit on the chest wall, movable, and wait till you see how much they vary between producing milk and not. You look at someone that's lactating, and the glands are just expanded, and just the ducts are big. You can see milk, if you take a histological section of it. And then if you're not, the glands are much smaller, and you have a lot more connective tissue. Connective tissue fills it everywhere. So, and this even changes monthly. People with their monthly cycles, their breasts will enlarge and get more tender during their monthly cycles even. But it's really apparent near the end of pregnancy and during lactation, where the breasts just change so much. And these hormones, ejecting the milk, oxytocin. Producing the milk, remember the hormone? It was one from the anterior pituitary. Prolactin. Yeah. So these two hormones are very important in breastfeeding. And this goes into a little more detail, pretty interesting here. At puberty, of course, the breasts start growing. And so the influence of estrogen will cause fat deposition in the female breast to start developing. And then during pregnancy, a lot of estrogens are given off, right? All kinds of estrogen and progesterones will cause the glandular tissue in the breast to grow like crazy. And the placenta even gives off this lactogen. The placenta gives off something too. So here's a little kid down there saying, come on, breasts, I need milk a little bit later. So start growing them. So you have this 9 months to prepare the breast to make the milk after childbirth. Now, prolactin makes the milk, but you don't want to start making milk and second month into pregnancy, right? You want to wait till birth and then start making the milk. So prolactin is actually, you can see that this placental hormone actually blocks prolactin. But once childbirth, the placenta is also born, and you're no longer making that placental lactogen, and then prolactin is free to cause milk production in the breasts. And so prolactin will make the milk production. And then as long as you're breastfeeding, it's actually psychological and physical. It's the stimulation of the breast and also the cuddling and the holding of the baby to the breast is going to cause oxytocin release and will continue to produce milk. And then if you don't breastfeed, milk production will dry up. Breast cancer is up there after skin cancer in females as a common cancer. So that's why the importance of breast exams is to look for those lumps. And if you feel something unusual, just go get it checked out. It can often be benign, or it could be something you catch early and be able to do something about it. Looking at the risk of breast cancer, see, most of you out there are less than 25. You can see 1 in 20,000 chance. So, but look at how this changes. Only at age 30, it goes to 1 in 2,000, 2,500 chance. So as you get older, much more likely to have breast cancer. Now we'll finish up. I'll just briefly talk about STIs and birth control. You can also call it STDs, sexually transmitted diseases. But you can be asymptomatic, so you can have an infection and not even have any symptoms. And so sexually transmitted infections, STIs, is more accurate. Just interested looking at the states, where we fall in STI rates. I looked at the worst is Louisiana. And again, I have no idea what's causing these differences here. It has the highest rates of STIs in Maine, New Hampshire, Vermont. We're looking pretty good in there. Yeah, looking pretty good. So what are the culprits here? Mainly we're talking about viruses and bacteria, some protozoan, some fungal, but these are the two biggies. And just like any other infection, like COVID or any other infection, the common cold and the flu, all these things, Lyme disease, these are organisms that are trying to survive out there, and they just happen to be transmitted by sexual contact. It doesn't have to be sex; it can be sexual contact, right? And some of them affect just the sexual organs, and some of them the whole body. Like HIV, it's going to cause overall effects, whereas others just cause things more localized. Symptoms, obviously, of these STIs would be you can have no symptoms, or you could have painful urination, or you can see sores or bumps. Things if anything seems unusual, you should just get it checked out. The ones that are bacterial are easily gotten rid of with antibiotics, but things that are viruses are a little harder to shake. And people can be asymptomatic and still spread the disease, which is why it keeps spreading. And like COVID, if we could, we're doing the stay at home order. If we could have everyone stop having sex and then test everyone and then treat those that have the disease, we could wipe out chlamydia and gonorrhea, things like that. But I don't think that's going to happen. But again, that's the thing. So it stays in our population because it's just passed around by people, and it's just going to continue. Sorry. Yes, and so looking at, besides colds and flu, widespread around the world, of course. This has been with us a long time, STIs. And because you guys are young, most of you are less than 25, just thought I'd say about half of the people that have them are young people. Probably more sexual partners, but I don't know. So these, again, I'm not going to give you a whole, I'm going to go through all of these. You don't have to know all. You need to know just the basics, like the ones that are viral, HIV, herpes, and HPV. These will stay with you. We have antiviral drugs, and HIV we know about since the 80s. A lot of, it's not the same prognosis as it used to be. There's a lot of combinations of drugs that will really help people live pretty normal lives. And then the two most common ones, STIs, would be chlamydia, number one, and gonorrhea, probably number two. They're bacteria, and they're transmitted into the urethra and into the sexual parts between partners. If you have it, they give you antibiotics, and it goes away. But you can be reinfected again. You can get it again, but at least we can almost easily gotten rid of with some antibiotics. Syphilis, too. It sounds scary, syphilis. And if you look back at medieval times, syphilis caused people to go crazy. It can travel to your head, and it can cause your skin sores and everything. But now antibiotics gets rid of it. Yeah, we don't see as much of that. Yeah, all right. I think that's pretty good. And condoms can help prevent a lot of these. Obviously, not having sex, but it's like saying, what's the safest way to ski? Not go skiing. It's kind of I don't know, it's kind of cop out, I think. But so these are things that are worrisome, and so you want to be safe. You want to get things checked out if things don't seem right. Here's my STD talk. Huh? And lastly, how to have a baby or not have a baby. And if you're infertile, I mean, you're doing the opposite of this. You're like, well, what can I do to have this baby? And what couples will do is figure out the ovulation time and have a lot of sex right around that time, a few days in either side. And you can carefully watch your temperature, and you can look at the calendar, and you can pretty much guess around your ovulation dates, but people vary quite a bit. And then if you're still infertile, you keep trying, and you're going to look at either the man or the woman could be the issue. It could be sperm counts or abnormal sperm, or it could be a problem with the oviducts or ovulation. And of course, you know, with new technologies, we can do test tube babies, not only test tube, but we can put sperm and egg together in a petri dish, and then put it in the female, and you can have egg donors. So anyway, let's go to the other end. How not to have a baby, all right? You listening? You recognize some of these things, the condom, the pill, and this is a diaphragm. This looks like some kind of toy. You shoot these little styrofoam things. I don't know what that is. I guess I should, right? And then this is an intrauterine device. You put that in and it prevents implantation. So it doesn't prevent ovulation, doesn't prevent fertilization, but it can't be, embryo can't develop in the uterus. I suppose the strings are, you can get it out. So contraception is trying not to get pregnant. And honestly, I can't really get into all of this, but just in sociology aspect, this women having control over their bodies and being able to have contraception elevates them, to allow them to be to go to education in order to do different things. When women can only have children and they don't have the ability to have any choice about it, it limits them in society. So I'll just put that out there, big picture kind of thing, is this ability for women to control their bodies is an important thing, and important for them in order to live the lives they want to live. Abortion is just terminating the pregnancy. They can, it's legal in this country still, and they can go in and stop the pregnancy. We'll talk about contraceptive methods. Before that, there's various levels we can stop this. One is to prevent this egg from being ovulated or sperm from being produced. They're working on like a male pill. Secondly, if you do have an egg, just keep it apart from the sperm. You have a barrier like a condom. Or like that intrauterine device, allow the sperm to meet the egg, but then don't allow it to implant, and you won't get pregnant. So I found this. You can see how helpful it is looking at the different levels we can prevent pregnancy. So at the very top, you can see a vasectomy. You produce sperm, but then they hit a roadblock and they just get absorbed by the body. Or birth control pills, they work by their hormones and they keep you from ovulating. So they work at that top level there, right? But let's say you're not stopping ovulation, and instead you want to stop the sperm from getting in the vagina. Well, a condom will do that. Well, the sperm will be there, but they're going to hit a latex wall instead of a brick wall. They're going to hit that. Obviously, abstinence. Like I told you, you can always throw that in there. Or coitus interruptus, the idea of pulling out, of trying to not put the semen in the female. They put in their high failure rate because some people go with that one, and yeah, it's works sometimes. But yeah, so that's going to stop the sperm from being put in the vagina. But let's say it is put in the vagina. Well, then you can have a diaphragm, a kind of a shower cap over the cervix to keep that sperm from getting from the vagina into the uterus, so it can't find the egg. Or spermicides, jellies, and things that will kill the sperm in the vagina, so there's nothing that can swim up and make it up that far. But interesting too, I should say, that swimming up, because the sperm don't swim all the way. And another sociological behavioral thing that's interesting is that the female orgasm, where am I going with this, right? What happens is that you release oxytocin, and the tubes in your oviducts and the uterus and your cervix actually dips down, and it's found to actually pick up the sperm when it dips down in there. So women, when they are with a partner having an orgasm, are more likely to get pregnant. And back in evolutionary time, rape was common, and and the insects and things like that. The males will mate with the females, not much they can do about it. But maybe this pair bonding and this female choice in who's going to fertilize their eggs could be involved with that. Anyway, I thought interesting stuff. But let's say the sperm meet the egg. Yep, and they make it down into the uterus, and then you can stop it implanting. And so you can have intrauterine device, this little T made out of copper or metal that just prevents the implantation. Or morning after pill. You can take drugs that you can take for days after sex that will prevent that implantation. So you fertilize an egg, it's just that that egg will be sloughed off with the, you won't even know it, with the menstrual cycle. All right, how's that? I guess we have a big list in your book. You can look at all these different factors. Actually, I'll show it. That's actually my last slide after this. This shows a vasectomy and a tubal ligation. So these should be considered permanent. You can reverse the vasectomy, but it's not 100%. It's expensive. So, but these work really well if you're done having kids and you don't have to have any worries. All right, here's the last chart. You can take a look. And again, I don't need to go through birth control with you guys. I hope in your education so far that this was taught to you. I'm going to point out some interesting things. Let's say you don't do anything. Looks like here 85 out of 100 women get pregnant. So you could roll the dice and maybe you won't get pregnant, right? But obviously 85% is not a very good number if you're trying to not get pregnant. Let's look at the worst ones here. Let's see. Rhythm method. That is the idea where you figure out when your ovulation time is and you don't have sex around then. You have sex other times, but you can see 20%. Wow, these sponges and stuff has a wide variety, a wide range, I guess, if it works or not. Yeah. Another bad one here. Oh, withdrawal. Yes. 4 to 18%. That's a big range too. But you can see even in pre-seminal fluid, there is some sperm. So I'm taking a big risk there. All right, what's some good ones here? Condom, 2 to 12%. Obviously, vasectomy and getting your tubes tied are very, very effective. That piece of metal you put in your uterus, pretty good. Wow, this medroxyprogesterone acetate. That is, what's the name of that? There's a, it's used also for treating some other endometriosis, things like that. But it's going to prevent ovulation. So you can see that's pretty, 0.3. And what is the, 3% for taking the pill, huh? So this one's a little like a better version of the pill. I'd say better, I mean more effective. It has other side effects. But taking the pill is going to provide you with levels of estrogen and progesterone that are going to prevent ovulation usually. And with few side effects, there's some things, especially combined with smoking, can cause some issues. But it's been a long time the pill has allowed easy contraception for women. The male pill has some issues. Not as easy to stop sperm production without other issues. So, and there's also issues of trust and other things like that, which I don't want to get into. I want to, but I won't get into that. All right. Yes, there's an egg with some sperm on it. One of them, the first one to make it through. We don't get to the pregnancy chapter. Feel free to read that. But one of them will find its way, eat its way through this coating around it, and then it will change it so that's the only one that can fertilize it. All right, class. I'm gonna say goodbye. Obviously, I'll talk to you some more, but this is the last lecture that I will post. And good luck, and I'll talk to you all again soon.